So for our first talk, we have mesenchymal stem cell therapy modulates intestinal injury seen in necrotizing enterocolitis, a premature piglet study. And this will be presented by Dr. Jasmine Lee, coming to us from Indiana University. The discussant for this will be Dr. Gail Besner from Nationwide Children's Hospital.
We have no disclosures. Necrotizing enterocolitis is a devastating disease which affects the intestines of premature infants. Despite numerous efforts for better diagnosis and therapy, NET continues to be a leading cause for neonatal morbidity and mortality and is the single leading cause of death in neonatal gastrointestinal disease. Mesenchymal stem cell, or MSC therapy, is increasingly recognized as a promising approach for treating numerous neonatal diseases, including necrotizing enterocolitis. MSCs possess many appealing characteristics listed here that make them well-suited for therapeutic application. Moreover, MSCs can differentiate into multiple cell types and generate a diverse array of signaling molecules that exert potent effects on other cells and tissues. Our lab, among other labs, has demonstrated the therapeutic potential of stem cell therapy in NEC, with consistent benefits seen in rodent models, including reduced injury, decreased inflammation, and improved survival. Still, these models have clear limitations in replicating human neonatal physiology and intestinal development. This makes large animal validation, particularly in the preterm piglet, a critical next step towards clinical translation. Our central hypothesis is that mesenchymal stem cell therapy in NEC will reduce intestinal injury using a preterm piglet model. By testing this hypothesis, we hope to provide more translatable data that supports future clinical application. Here are our methods. Premature piglets were delivered via cesarean section on 103 days of a 115-day gestation. That's representing about 90% of term. Control piglets were sacrificed on postnatal day 1. All remaining piglets received TPN starting on day 1. NEC was induced beginning on day 3 with the initiation of hypertonic enteral feeds. On the same day, mesenchymal stem cells were administered intraperitoneally at one of 3 doses, low, medium, or high listed here, while NEC controls received PBS alone. There were 6 to 9 piglets in each treatment group. Piglets were monitored hourly for clinical deterioration and euthanized early if criteria were met. The study concluded on day 5, at which point weight change, clinical score, and blinded gross intestinal injury score were collected during necropsy. Here are our results. This slide highlights 3 clinical outcomes following stem cell therapy in NEC. First, we observed a significant reduction in clinical sickness score in all stem cell treated groups compared to the NEC group, suggesting a robust therapeutic effect across all doses. Although weight gain and loss did not differ significantly between groups, the high-dose group was the only one to exhibit overall weight loss, which may reflect a dose-related metabolic response or greater disease burden. Lastly, survival analysis with a Kaplan-Meier analysis demonstrated that all 3 stem cell doses resulted in significantly improved survival. This further supports our data that the medium dose is the best in this model. This slide represents the macroscopic intestinal injury scores. Only the medium dose stem cell group receiving 1 million cells per kilogram demonstrated a statistically significant reduction in gross intestinal injury compared to the NEC control. To illustrate the range of injury, I've included representative images from the bowels at various scores. Lower scores, like 1 or 2, reflect minimal injury, while higher scores, like 5 or 6, indicate severe disease characterized by extensive necrosis and pneumatosis intestinalis. This slide highlights the microscopic injury grading based on blinded histologic analysis of intestinal tissue. We observed a significant reduction in histologic injury grade in both the low and medium dose stem cell groups compared to the NEC group, indicating that stem cell therapy mitigates microscopic damage. However, the low dose group still demonstrates a significantly higher grade of injury compared to controls, whereas the medium dose group showed no difference from the control group. These findings further support the medium dose as the most optimal dose. And here are our conclusions. First, stem cell therapy significantly improved clinical sickness score and survival in NEC piglets. Second, medium dose, the 1 million cell per kilogram group, significantly reduced both macroscopic and microscopic intestinal injury. This highlights the medium dose as the optimal therapeutic dose for clinical and structural protection. Some limitations of our study include the smaller sample size, a short study duration of 5 days, and kind of a lack of an ideal control group as non-neck piglets were sacrificed on day 1 and could not receive maternal care. Understanding the mechanism behind how stem cells confer protection in neck is critical for translating this therapy into clinical practice. Therefore, our future investigations will focus on the medium dose, which demonstrates the most consistent clinical and histologic benefit. To uncover the pathway involved, we are performing RNA sequencing and PCR analysis to analyze the expression of key signaling molecules within intestinal tissue. Additionally, we are conducting cytokine profiling of the piglet's serums to assess how stem cell therapy influences the systemic inflammatory response. I would like to thank my mentor, Dr. Markle, the entire Markle Lab, and our collaborators in veterinary medicine for their support. I'm happy to take any questions at this time.
Can somebody, oh yes, the microphone is working. First of all, congratulations on a really nice study, such that we've come to expect from the Markle Lab. I applaud the investigators for assessing their mesenchymal stem cell therapy in a large animal model of neck in order to corroborate their very impressive small animal results to further strengthen their preclinical data. The pig model of neck is costly, it's challenging, it's labor-intensive, but it's really necessary in order to move these studies to the clinic. We've used this model for several years and have noted several important observations. For example, we often note that macroscopic injury score correlates poorly with histologic injury score, clinical sickness score, and survival. So it was really nice to see that you did have a correlation in all of those realms. I wonder if you could tell us why you think that the middle dose therapy is more effective, for example, than the high dose therapy. And secondly, in your rodent studies, you've shown, as have others, that engraftment into the intestines is not actually needed. And so I wonder if you speculate that the same will be true in the large animal model. Congratulations again on a beautifully conducted and presented study.
Thank you, Dr. Bresner. So going into these studies and having so many successful studies in rodent models in the past, the most important thing for us was finding out an optimal dose at the piglet model to find out which dose we could continue our studies to learn more about the mechanism of why stem cells work in neck. So we kind of picked these 3 different doses, one that's lower than the dose that we traditionally use in mice, and one significantly higher than the dose we use in mice. We did expect going in that perhaps it would be similar to our mice data, and the 1 million cells per kilogram dose, which does replicate what we use in our mice studies, would work the best. But it was interesting to find that the lower dose is protective in some levels and does have the clinical sickness is better in those piglets. But at the gross intestinal score, those were some of the sickest patients. And then on the opposite end, the high dose showed very sick gross intestinal scores and had, in fact, the worst histologic grading as well. So it shows us that there's a very clear balance of where stem cells can be protective. It's great that we found it so that we can move forward with further studies. Thank you for your question. Yeah. Engraftment. I do think engraftment's important now that we have solidified which dose we're going to use with studies moving forward. We are going to do studies like we have done in our mice models to test that better in piglets as well. Thank you.
Any other questions? Very beautifully presented. Thank you.
Thank you.
Good morning, and thank you for the opportunity to present our work on intestinal fatty acid binding protein, or IFABP, and its potential as a discriminating biomarker for necrotizing enterocolitis. I have no disclosures. As we all know, NEC is a complex disease in which the stress of prematurity and enteral feeding can ultimately lead to intestinal ischemia and bacterial translocation, all of which combine to form the clinical picture of what we know as NEC. Intestinal fatty acid binding protein, or IFABP, meanwhile, is a protein that's specific to the intestine. It resides within enterocytes and as such is not detectable in healthy states. However, when enterocytes sustain damage, it's released and then becomes detectable within the blood. Because of this, we've previously looked at IFABP as a biomarker for NEC, first in piglets, where you can see those that had fulminant and non-fulminant NEC in blue and red respectively, had elevated levels of IFABP compared to healthy piglets shown in green. We see a similar pattern in our patients as well, in which case we see elevated levels of IFABP in those that went on to develop NEC, specifically here with increasing feed volume, indicating a relationship between the release of IFABP and enteral stress. Given this, we're confident that there is a difference in IFABP levels in patients that have NEC compared to healthy controls. However, we wanted to determine if IFABP could distinguish between NEC and other abdominal pathologies. We hypothesized that it's elevated in patients with NEC, distinct from those with these other diseases that can have similar presentations. We prospectively collected residual plasma samples from patients born in our NICU at less than 34 weeks gestation, and our exclusion criteria are as follows. We quantified IFABP via ELISA, and once our samples were collected, we then conducted a chart review to identify patients that had necrotizing enterocolitis, specifically Bell stage 2 and 3, as well as those that had spontaneous intestinal perforation, which we defined as an isolated perforation in the absence of further enteral disease, feeding intolerance, which we defined as cessation of feeds in the setting of abdominal distension and emesis, and sepsis, which we defined as systemic illness in the setting of positive blood cultures. Over the course of 1 year, we were able to enroll 69 patients with available samples, of which 53 were healthy, 7 had NEC, and 9 had other abdominal pathologies, specifically 1 with SIP, 3 with feeding intolerance, and 5 with sepsis. Once these patients were identified, we then selected 8 healthy corrected gestational age-matched controls. The demographics of our patients are as follows. Excuse me. As you can see, we did have a significant difference in the birth weight between our NEC cohort and our other populations, which is to be expected as this is a risk factor for the disease. But they were well matched in terms of gestational age at birth and matched at age of diagnosis for those that had the other diseases. What we found is that our IFABP levels were elevated in patients that had NEC compared to healthy controls, as we expected, but they were also significantly different from those that had other abdominal pathologies. And this is a pattern that was demonstrated not only at the time of clinical diagnosis, but also prior to and following. We then conducted a ROC analysis and found that a level of 2.5 had an 88% sensitivity and 100% specificity for NEC at any time the sample was drawn. Looking specifically at when the clinical diagnosis was made, a level of 5.1 had 100% sensitivity and 100% specificity for necrotizing enterocolitis. Our study does have some limitations, namely the fact that these were non-standardized blood collection times as they were scavenged samples, which makes it somewhat difficult to compare. And additionally, as these were routine lab draws, there were fewer samples available from healthy patients. And this may also contribute to that significant difference in birth weights. But in conclusion, a plasma IFABP greater than 5.1 is both sensitive and specific for NEC at the time of diagnosis, and a level greater than 2.5 can distinguish NEC from other abdominal pathologies early in the disease course. This may aid in an earlier diagnosis of NEC when the presentation is still nonspecific and can potentially prevent unnecessary antibiotics and feeding cessation in those patients that don't actually have NEC. We also hope this will help us identify patients that can be candidates for novel therapeutic interventions, such as the one we just heard. Moving forward, we do still want to further validate this in patients with other abdominal pathologies. It's an ongoing study, and we're hoping to have enough patients so that we can look at each disease individually. And we're in the process of developing a bedside test for improved clinical utility, as it's currently an IFABP that we do in our lab. Thank you for your time.
Dr. Wright, thank you very much. I would like to congratulate you for this excellent paper, and congratulate you and your group, and Dr. Olutoyo, obviously, who has been leading this research. Now, this is an excellent report, an excellent study that highlights the importance of IFAB, this fatty acid binding protein, to distinguish from other diseases. And this is very important for NEC because we don't have a single specific marker for NEC, so this will be extremely important. I would like to go back to the release of IFAB in circulation. Normally what we know, that IFAB is released in circulation when you have a death of the enterocytes. So there is a significant insult to the intestine, particularly with mesenteric ischemia. This is how it's been initially discovered, and then also supported by other studies in neck. Now, your data seems to indicate that the elevation of IFAB occurs even before, days before the occurrence of neck. Would you mind to speculate, how do you think the release is happening in those cases? Secondly, okay, go ahead, please.
Oh, sorry. As you said, it is definitely a speculation, but I do wonder if that initial insult has some death of enterocytes before the ultimate ischemia happens, and that could be why we see lower levels earlier on in the disease.
Okay, well, thank you. Very interesting. The other thing is that years ago, in 2010, we reported the elevation of IFAB, my group, in babies with neck, and we found that the more significant the disease is, the more advanced the disease, the higher the concentration of the release. In that case, we use urine. And did you look at the level in different stages of the disease, for instance, comparing the one with medical treatment alone versus surgical treatment alone? And also, we found that after the disease is subsiding, the levels go down, whereas in your study seems to be remaining quite high a few days after the procedure. Can you comment about that?
Absolutely. So we weren't able to find a correlation in our sample between the disease severity and the level of IFABP, but this could be because when we separate them into 2A, 2B, 3A, and 3B, none of those groups had any more than 3 patients. So we're hoping as we increase our number, we can potentially identify some of those patterns. In terms of the levels remaining elevated, given that these were scavenged samples, we didn't look beyond about 5 days after the diagnosis, and we did see somewhat lower levels, even though they were still elevated compared to those with the other diseases.
Okay, finally, just one comment. We and others measure urine metabolites, urine fatty acid binding protein. Now, obviously, this is an advantage because it's less invasive. Can you comment about why blood and not urine, for instance?
Right. We wanted to validate this model specifically in blood first, as there are fewer confounding factors, given that the urine levels can be related to creatinine and the general hydration of the patient itself. So we wanted to prove that this was a relationship that could be seen in blood before then moving on to urine.
Very good. Congratulations again. Thanks.
Thank you.
I'm pleased to present our work on maternal plasma microRNAs and fetal congenital diaphragmatic hernia. We have no disclosures. CDH risk stratification is limited to anatomic information. There are numerous options to choose from, as you can see here. However, physiologic data to complement the imaging parameters is sparse. Things like the pulsatility index are difficult to reproduce and operator dependent. Amniotic fluid biomarkers require an invasive procedure, and tracheal aspirates have been used in patients who require FETO, obviously not representative of the general population of CDH patients. However, maternal biomarkers, like microRNA, have shown promise in other fetal diseases, suggesting they may have utility in CDH. We already know that microRNA isolated from maternal blood is useful for diagnosis and risk stratification in TTTS. Differential expression of microRNA has been seen in amniotic fluid for fetal cardiomyopathy. Tracheal aspirate microRNA can predict responsiveness to FETO, as already mentioned. And that neonatal blood possesses a unique microRNA profile in CDH patients who develop chronic lung disease. We therefore aim to see if maternal plasma microRNA potentially held any information as to diagnosis and risk stratification for CDH. We did this study in an attempt to provide physiologic data to supplement the static anatomic risk stratification systems, and want to highlight that this is important because this information can be readily obtained simply from a maternal peripheral blood draw. We hypothesized that maternal plasma microRNA can be used to both diagnose and risk stratify the disease. We obtained maternal peripheral blood from 20 women pregnant with babies with CDH and 8 controls in the 2nd and 3rd trimesters, centrifuged to isolate the plasma, extracted the microRNA, and then performed whole genome microRNA sequencing, analyzing the results with DSeq-2. When comparing our CDH patients to the healthy pregnant controls, we identified 17 differentially expressed microRNA, highlighting 3 already established in the literature as related to either CDH or pulmonary hypertension. Individually, each microRNA is moderately accurate in distinguishing CDH from non-CDH pregnancies. But when combined, the ROC curve has an AUC of 0.93, showing a high degree of predictive capacity. Next, we examined just the cohort of CDH patients delineated by our institutional risk score. Here is a PCA plot showing 2 distinct clusters between mild cases and severe cases, potentially supporting the existence of a disease-specific circulating signature. We then did a sub-analysis, comparing markers of clinical severity, like an intrathoracic liver, in those who required a more extensive repair, and identified differing numbers of differentially expressed microRNA, suggesting their potential utility in risk stratification. Notably, we found no difference when we examined patients who required ECMO, likely related to our small sample size. We took the microRNA from each of these sub-analyses and plotted a Venn diagram to determine if there was any crossover between our results. We ultimately identified 10 microRNA that appeared in 3 or more of these clinical markers of severity. Among those 10, we would like to highlight 3, based on our review of the literature, underscoring their potential as non-invasive biomarkers. LET7C, MIR98, and MIR30D have separately been identified from different biological sources, including amniotic fluid in CDH pregnancies, blood from neonates with pulmonary hypertension, or CDH, animal models for studying pulmonary hypertension, and in endothelial cells under hypoxic stress. We have now been able to identify them prenatally through a non-invasive method from maternal circulation, supporting their relevance for risk stratification. To summarize, maternal plasma in CDH pregnancies shows a distinct microRNA profile. Although the diagnosis of CDH can be done with ultrasound or MRI, it does not normally occur until the 2nd trimester. First trimester maternal blood draws examining microRNA may potentially be useful in this regard, similar to how maternal serum AFP is used for spina bifida and gastroschisis. Second, disease severity also seems to correlate with specific microRNA, which may potentially supplement our current imaging-based criteria with further investigation. Lastly, the circulating microRNA identified have previously been linked to pulmonary hypertension pathogenesis. Ultimately, we hope that these results may potentially lead to microRNA therapeutics for fetal disease treatment. Thank you for your time. I'm happy to take any questions.
Thank you for the opportunity to present our talk. This is our disclosure. We did this research to see if an early gestation maternal blood test may improve our ability to predict congenital diaphragmatic hernia, or CDH, severity. We have previously shown biomarkers exist in 3rd trimester serum, but find our 2nd trimester time point more clinically relevant, as it could potentially distinguish candidates for fetoscopic endoluminal tracheal occlusion or fetotherapy. CDH is characterized by incomplete diaphragm development, permitting abdominal organs to herniate into the thoracic cavity. It has prevalence and mortality rates as shown, with associated cardiopulmonary morbidity. At our institution, we utilize ultrasound and MRI as imaging characteristics have been shown to predict CDH severity. Through ultrasound, we can see liver herniation and calculate an O to E LHR, or observed over expected lung-to-head ratio, and with MRI, O to E TLV, or observed over expected total lung volume, and PPLV, or percent predicted lung volume. Cases with O to E LHR less than 25% are considered severe and qualify for feto, depicted on the right. The ideal fetal candidate is largely unknown. Although imaging is efficient in providing us with some predictions, there are limitations. These are our receiver operating characteristic curves, or ROC curves, showing our institutional unpublished data comparing how well O to E LHR and O to E TLV are at predicting ECMO utilization. While we work on mortality data, ECMO is used as a surrogate for severity. It shows fetal ultrasound ODE LHR in red with an AUC of 0.68 and MRI ODE TLV in blue with an AUC of 0.73, establishing limited predicted utility. We believe a maternal blood test to identify serum biomarkers will enhance prenatal predictions and serve as an adjunct to imaging. MicroRNAs are small, non-coding nucleotide sequences that regulate gene expression and have emerged as promising biomarkers for various diseases. Their presence in serum, protection within exosomes from degradation, and ease of obtaining blood samples make microRNAs ideal biomarkers. We hypothesize that random forest analysis of second trimester maternal serum microRNA will identify signatures that effectively distinguish CDH survivors from non-survivors, with potential implications for guiding fetotherapy. We collected second trimester maternal serum and performed microRNA sequencing. We applied random forest analysis to these microRNA sequencing profiles, which is a machine learning tool to distinguish biomarkers, distinguishing CDH survivors from non-survivors. We analyzed a total of 12 maternal samples with 7 survivors and 5 non-survivors. This is a volcano plot representing our microRNA sequencing data comparing CDH survivors and non-survivors. A total of 441 microRNAs were identified, represented by each dot. Those in color are significantly different between groups, with 15 downregulated and 7 upregulated in red. Random forest analysis identified a panel of microRNAs that effectively distinguish CDH survivors and non-survivors. The variable importance plot highlights the predictive power of these microRNAs, with dots to the right showing an increased ability to differentiate outcomes. Our top 3 are highlighted here. To validate the predictive power of these top 3 microRNAs as biomarkers for CDH outcomes, we used an ROC curve to assess its accuracy. The ROC exhibited an area under the curve of 1, indicating high specificity and sensitivity of these 3 microRNAs to predict CDH survival. Here are box and whisker plots of the top 3 microRNA expression fold changes comparing survivors in blue to non-survivors in red. MicroRNA 376C3P is down, while microRNAs 18A3P and 194-3P are up in survivors compared to non-survivors. Our analysis identified microRNAs in second trimester maternal serum that effectively differentiate CDH survivors from non-survivors. For future directions, we have some preliminary data validating results with PCR, are sequencing 8 additional samples, and would also like to expand our study across institutions as there are variations in practices and outcomes. Although there is more to do, distinguishing these early gestation biomarkers offer key insights into the prognosis of fetuses with CDH. Thank you very much.
We would like to now invite Dr. Tippy McKenzie, coming to us from the University of California, San Francisco, to be the discussant for these 2 wonderful presentations.
Thank you so much, and congratulations to both of you on this wonderful work. These 2 abstracts highlight a critical area of discovery, I think, in fetal surgery and that of precision medicine. So when we see a patient in the clinic postnatally, the radiology studies, of course, are only one layer of the information we use to make a diagnosis and make a decision about what to do. Fetal surgery, for all the advances we've made, lags behind. So yes, we've developed widely accepted measures of lung volume to try and predict how sick we expect the child to be at birth. But at the end of the day, what we're doing is measuring an anatomic quality, that of lung volume, and trying to predict pulmonary vascular hypertension. And so it's a tool, yes, and it's been used to decide who gets fetal tracheal occlusion, how we cancel families, but we can all agree, I think, that it's a blunt tool. So I think these kinds of studies are really critical for helping us advance the field. And this kind of effort has, of course, so many different implications, as was mentioned, for twin-twin transfusion, perhaps gastroschisis, perhaps SCTs, so kind of the list goes on. So I'm supposed to ask you guys, I don't want to ask 2 different questions because they were very similar studies, but I was really struck by the fact that here are 2 excellent studies from 2 excellent labs, and you guys came up with a different list of the important microRNAs. And I think that's a critical kind of gap in the field, is how do we conduct these studies? What sort of sample size do you need? So I wonder if you can sort of comment on the variability that you see between patients. What do you think is the sample size we need? And what do you think is the critical time period? Because I also noticed that the time period in which you gathered your microRNA, your maternal serum was different. So go ahead. I hope that wasn't too hard a question.
No, that's a great question. That's something that we talked about in our lab a fair amount. If you look at microRNA studies across the board, cancer, fetal, whatever it may be, you're right, there is significant variability between the studies that we look at. And I think part of that is because studying microRNA is a relatively new field. And I think another part of that is if you look at microRNA networks, they're massive. Two of the ones that we had highlighted, LET7C and MIR98, are actually part of the same family. And if you look at the systems that they interact with, it can be multi-systemic, essentially. So I think some of the specificity associated with microRNA isn't quite there yet, but will be better as we continue to look at things. And then I think one of your questions too was related to the timeline at which we get this information. There's some pretty good research so far that shows that women in general, when they're pregnant, actually have a microRNA profile that changes throughout pregnancy. Early first trimester is different than late first trimester, is different than second, is different than third. So that's one thing that we would like to look at. Is there a difference between first and second when it comes to CDH and second and third? And does that correlate with severity as things change? Because like, as a fetal surgeon, I'm sure you've seen patients who come in with what you would call mild disease at 22 weeks, and they come back at 30 weeks and it's severe. So things seem to change in that regard. And I do think microRNA potentially could be helpful in looking forward.
Thank you.
Yeah, to elaborate on that, I agree. I think that there's a lot to do with microRNAs, especially with profiling. With our type of analysis, when we did the random forest analysis, it actually is complementary to have a very large data set to then distinguish decision trees and then help us predict outcomes. But we also had a previous study where we looked at third trimester cord blood, amniotic blood, as well as maternal serum, and we saw different microRNAs in all of those different subsets. And then this is an offshoot of that, so we're looking at second trimester in this particular study, but it is interesting that there are all different microRNAs, and I think it just shows that there's a lot more work to be done. Looking at my specific top three microRNAs that suggested high specificity and sensitivity, those actually did not show, they weren't necessarily in pathways or in the literature shown to be associated with pulmonary hypertension or other cardiopulmonary morbidities, and have primarily been shown to be recognized within cancer studies. So I think, a lot of the funding goes towards cancer for microRNA profiling, and I think that we're showing that, we should look into microRNAs in the maternal side as well.
Thank you both.
Could you guys tell us some about the trafficking of these microRNAs? Are they thought to be fetal origin or are they maternal origin?
Actually, that's a great question, and we are still working on figuring out exactly where they're coming from, whether or not they are maternal or fetal.
We have a question.
Yeah, good morning. Thank you very much. My name is Richard Keijs. I'm from Winnipeg. I've done quite a bit of work on microRNAs, and I'm excited to see these developments. I was wondering if you took the biological sex of the fetus into account. We've seen quite a bit of differences that were sex-specific in some of these profiles.
I didn't include it in this presentation, but we looked at sex to see if there was any type of differential expression between male and female. And in our study, I think it was a perfect 50-50 split. We had 10 males and 10 females, and we didn't see a difference. Like you pointed out, looking in the literature, there are sex-specific differences. So it's unclear if, from our study, if there wasn't a difference or we were just underpowered to detect that.
Thank you.
Any other questions?
Hi, Jim Pierce from Central California. So just to get back to the power analysis, there's actually, obviously you can't have more predictors than you do final outcomes. It's been studied quite a bit actually, how to figure out how many. There's like the chemist and Kepler, the simple trick of 20 plus 5 times the number of predictors. So for like 20 microRNAs, you need like 120 patients at a minimum. Although if you do some of the more advanced calculations, it'll probably be in the 600 and 900 number of included patients. One of the tricky things I noticed in your methods, there's the difference. We're going to be seeing more AI and machine learning based algorithms, and I wonder if you could make a comment on if you think that when you use those techniques, you would need to be a little bit more selective in which things you include so as not to run into some of the power issues. Thank you.
Yes, so we did use AI as a machine learning tool, and I think that you bring up a very great point. One of the comments that we've had is overfitting of data based off of these types of analysis. And I think that we will have to be, as you mentioned, very selective in figuring out our criteria for determining our power analysis.
All right, great. Thank you both very much.
Pulmonary hypertension is one of the greatest challenges in the management of infants with CDH and a major determinant for the high mortality in this population. Abnormal lung vascular development is a central contributor to CDH-PH, which is characterized by reduced vascular density and vascular remodeling with thickening of the pulmonary arteries. The underlying pathogenesis of these abnormalities remains elusive. To date, no therapy has been successful in fully rescuing abnormal lung vascular development, but there is consensus that the prenatal period offers a window of opportunity to prevent pulmonary hypertension. In search for such a therapy, the Zeni Lab has been exploring the use of extracellular vesicles derived from amniotic fluid stem cells. We have previously shown that antenatal administration of AFSCVs rescues fetal lung vascular development in the nitrofen model of CDH in rats, but much remains to be explored regarding the pathogenesis of vascular remodeling and the effects of AFSCVs. So in this study, we aim to investigate the effects of mechanical compression on fetal lung vasculature and the mechanism of action of AFSCVs in rescuing lung vascular development. To study the effects of mechanical compression, we developed a microstatic compression system that mimics the pressure caused by herniated organs. We calculated a precise load, taking into consideration the forces that are present in the in vivo environment, and our results showed a load of 0.222 kilopascal. We applied this load by inflating a 6-French Foley catheter microballoon against healthy rat and human fetal lungs that were cultured in 10% Matrigel for 30 hours. To treat fetal lungs, rat and human AFSCVs are isolated and characterized according to the ISAF guidelines. EVs were administered intratracheally, followed by tracheal occlusion in rat fetal lungs, and topically to human fetal lungs. At 30 hours, fetal lungs were then harvested and allocated into normal compression or compression plus AFSCV groups. We observed that in both rat and human lung models, AFSCV rescued main features of lung vascular development that were disrupted by mechanical compression, such as lung vascular density, vascular remodeling, and the gene expression of key angiogenic markers. We also investigated the effects of EVs in the HIPPO pathway, a mechanosensitive pathway that has been shown to be dysregulated in CDH lungs. And we observed that EVs rescued the expression of key markers of the HIPPO pathway, including EAP, which are well-known regulator of VEGF. The question is, what is the key effector of AFSCV cargo that modulates these effects? We've previously reported that AFSCV cargo contains multiple small RNA species, And we then interrogated the AFSCEV cargo for RNA species that modulated the HIPPO pathway, and we identified 2 long no-coding RNAs that amplify the expression of YAP. They're named lincRNA TUG1 and MYET. Long no-coding RNAs, or lincRNAs, are molecules that play an essential role in organogenesis by regulating gene expression via sponging of microRNAs. To explore if these 2 long no-coding RNAs modulated the effects of AFSCEVs, we then silenced the expression of both in the AFSCEV cargo and then administered them to these knockdown EVs to compressed fetal rat lungs. We observed that TUG1 knockdown AFSCEVs, but not MYET, failed to rescue the gene expression of YAP and its downstream target genes. Moreover, TUG1 knockdown EVs failed to restore VEGF-A expression and other key angiogenic markers. So taken together, these findings suggest that lincRNA TUG1 released by AFSCEVs amplifies the expression of YAP, which then upregulates VEGF, rescuing fetal lung vascular development in compressed lungs. So in conclusion, mechanical compression impairs fetal lung vascular development and is associated with disruption of the HIPPO pathway, and administration of AFSCEVs rescues lung vascular development, at least in part, by modulating YAP expression via the liver of lincRNA. Therefore, antenatal AFSCEV treatment is a promising avenue to restore lung vascular development and potentially prevent postnatal pulmonary hypertension in babies with CDH. I would like to give a special thank yous to the APSA Foundation for supporting this study with the Grossfield Scholarship, and would like to close announcing that the Zani Lab has moved to Washoe and is recruiting trainees. Thank you so much for your attention. I'm happy to take any questions.
Beautiful presentation. I see we have some questions coming up to the mic. Dr. Kunisaki?
Thank you. Beautifully presented work. Once again, I'm just really impressed by the Zani Lab, what they've done, and it's nice to see that some mechanistic studies are finally being done on EVs, because I do think there's great promise for this for these kids. One question that I had is that in your model, the timing of the delivery of the EVs is fairly late, E19, which is fairly late in pregnancy, which begs the question, perhaps maybe this could be also translated postnatally. Have you guys explored the effect of these in later time points or earlier time points, and how does that affect the effect of the vasculature in your system?
Thank you for your question. It's a very good question. So first, the timing point of EV administration is, we decided to do at that timing point because it mimics what happens in clinic. So we wanted to be at the time of diagnose. It's also the canalicular stage of lung development, so it's the most relevant timing point for us in terms of application and translation to clinic. And we do not, with this specific model, the nitrofen model, it is quite challenging to do postnatal studies. So like long-term effects of AFSCEVs or later applications of EVs, it's a little complicated to in postnatal because these babies, they die really short after birth. But we do have considered, and we actually have ongoing studies on the effects of EVs in postnatal, other models, postnatal models. And we believe that the application of AFSCEVs might have, the study of application of AFSCEVs in different time points is really important, and we could actually do it earlier, as we've had other presentations showing that maybe an early diagnosis of CDH with different biomarkers could be an indicator of that these kids need early treatment, and that's also a possibility for us.
Thank you.
No problem.
All right, are there any other questions? Okay, thank you.
Thank you for the opportunity to share our work. We have no disclosures. In children with Hirschsprung disease, transosome pull-through may lead to persistent obstructive symptoms years after a successful pull-through. Transition zone pull-throughs are a well-established technical cause of a post-pull-through obstruction and are often responsive to redo surgery. Rectal remodeling, however, has been proposed as a cause of obstructive symptoms due to pathologic changes after a pull-through, which affect the neorectum and mimic the transition zone physiology. The incidence and significance of rectal remodeling is unknown. If clinically significant, rectal remodeling may explain symptoms in patients who have persistent symptoms after pull-through and may be a valuable area of future research. As many of us know, Hirschsprung disease is a failure of ganglion cells to adequately migrate to the distal colon, which results in a segment of dysfunctional colon. The surgical management of Hirschsprung disease is by the coloanal pull-through, in which aganglionic colon is resected and healthy ganglionated colon is pulled through to the anus to create a neorectum by a new anastomosis. However, our ganglion cells don't migrate in a uniform pattern. This results in a margin of tissue distally that may sporadically contain ganglion cells, which is known as the transition zone. The aim of the initial pull-through is to work back to normal tissue like this. Sometimes random biopsies result in surgeons determining that the transition zone is actually at this level, where there's occasionally an absence of ganglion cells. When there's this abnormal pathology containing both ganglionated and aganglionic cells at the proximal resection margin, this is defined as a transition zone pull-through. A transition zone pull-through has a very specific pathologic definition, including residual aganglionosis, hypoganglionosis, or hypotrophic nerves. However, recent research has suggested a new concept known as rectal remodeling. This is defined as pathological changes that happen after an initially completely normal pull-through, potentially due to the development of pelvic nerves into the neorectum that mimic the transition zone. The incidence and the clinical significance of rectal remodeling is unknown, but this could help explain symptoms in patients with persistent trouble after pull-through. Therefore, we approached our study with two aims. The first was to determine the incidence of a transition zone pull-through as compared to rectal remodeling in a patient with persistent obstructive symptoms following pull-through for Hirschsprung disease. Secondly, we aim to compare outcomes following a redo pull-through in patients with a transition zone pull-through versus rectal remodeling. To do this, we began with a cohort of patients who underwent a primary pull-through for Hirschsprung disease between 2012 and 2023. We narrowed this down to patients who had persistent obstructive symptoms, which led to a repeat full-thickness biopsy and ultimately to a redo pull-through. For these patients, we went back to their initial pull-through pathology slides. If the proximal margin of the original resection specimen was abnormal, indicating that the tissue pulled through contained a combination of ganglion and aganglionic cells, the patient was defined as having undergone a transition zone pull-through. If the patient had a normal appearing initial resection specimen, we then analyzed their repeat full-thickness biopsy. If this was also abnormal, the patient was then defined as having undergone rectal remodeling. We then compared outcomes, both in the cohort as a whole and between transition zone pull-through and rectal remodeling. During our study period, there were 232 patients who had previously undergone a pull-through for Hirschsprung disease and underwent a repeat full-thickness biopsy for obstructive symptoms. About half of these patients, or 122, had an abnormal biopsy. Of these patients in whom we had available long-term follow-up data, the majority, at over 90%, underwent a redo pull-through solely based on the concern for a transition zone pull-through on their repeat full-thickness biopsy. There were a minority of patients who underwent a redo pull-through due to concerns for mechanical issues such as spurs or twists. However, of the 77 patients with a suspected transition zone pull-through and 34 with available pathology to review, only 13 patients, or less than 40% of patients, actually had a transition zone pull-through in the first place. That means that over 60% of our cohort who had a repeat coloanal pull-through for what we thought was a transition zone didn't actually have a transition zone pull-through at all. They had developed rectal remodeling. Within this cohort, there were no differences in age at diagnosis, sex at birth, family history, the original transition zone location, the age at pull-through, or the type or approach of the initial pull-through. We then compared preoperative and postoperative outcomes in that order. Before the study and before redo pull-through, over 50% of our cohort were dependent on irrigations. After redo, this decreased to 10%. As we've discussed before our study, 100% of our patients experienced obstructive symptoms. Following redo operation, again, only 10% continued to experience these symptoms. And finally, almost 2/3 of our cohort had an episode of enterocolitis before their redo pull-through. In the time following redo, only 10% of these patients have had a subsequent episode of enterocolitis. We then compared post-operative outcomes from the redos done for a transition zone versus those that were eventually determined to be done for rectal remodeling. For each of these categories, there were no differences in our outcomes between these groups, acknowledging that these are very small sample sizes. It is important to note that there were also no differences in preoperative symptoms between these two groups. In summary, we suggest that in patients with persistent obstructive symptoms, even with an originally normal proximal pull-through margin, rectal remodeling may commonly occur. In these patients, a repeat biopsy should be performed to help identify rectal remodeling versus a transition zone pull-through. However, regardless of the etiology of pathological changes, patients with an abnormal biopsy who undergo a redo pull-through may have improved outcomes. Thank you to the teams both at Nationwide Children's Hospital as well as Seattle Children's Hospital for their collaborative efforts on this project and for the chance to share our work today. I'm happy to take any questions.
All right.
Andrea Bishop, Children's Hospital, Colorado. Congratulations on your presentation. My question is, for the patients that had a normal biopsy, how do you envision that they will not undergo the rectal remodeling again?
Yeah, it's a great question, especially as rectal remodeling has been theorized to happen in many patients, more so than just the ones with obstructive symptoms. It's not detailed in this talk, but again, about half of our patients with had an abnormal biopsy after their repeat full thickness. Of the children that didn't have an abnormal biopsy, none were offered a redo pull-through, and many of them responded to medical management. So certainly something we intend to dive into in further studies and within the manuscript, but it's an interesting avenue of future research.
Agostino Piero, Toronto. Again, congratulations for this wonderful study. I wanted to ask you if what you classify as normal pull-through in a normal segment has been done on a single biopsy or on a donut, because you may have underestimated the level of transitional zone at the original biopsy.
Sure.
And this obviously may affect your results.
Yes, thank you for that question. When we went back to review the initial pull-through proximal margins, that's based on the donut entirely, so not a single biopsy.
Okay, thank you very much.
Excellent study. Mohammed Imran, Corpus Christi, Texas. We previously had published on the looking at the vascular supply in the pull-through segment using ICG, and we found that about 2/3 of the patients, when you did the pull-through, where you thought you had good vascular supply, you either had diminished or absent vascular supply. We know that the nerves are sensitive to that blood supply. Do you think that the remodeling in this situation may be due to not properly assessing the vascular supply of those pull-through segments?
Yeah, thank you for the question. It's also a great question. I certainly think vascular supply has a role in this. I think the particular role of vasculature is not quite elucidated. It's certainly something to look into. Our lab has also looked at the use of ICG in determining adequate level for pull-through, and something we intend to look at further, but was not as part of this study.
Thank you for the talk. I have one more question. Could you tell us anything about the time course over which this develops? Because presumably it takes some time for remodeling to occur. So were these patients that had a period of normal stooling after surgery, and then when did they start having problems?
Yeah, also a great question. A little bit challenging within this study, as most of what we did was retrospective, and many of these patients were from outside institutions referred to us after a period in which either they were struggling and unable to be managed at their initial institution, or were completely fine and referred after a period of abnormal stooling. So hard to know. I think certainly as we look at this prospectively, something that we're keeping in mind in terms of understanding when changes happen and when the appropriate time for intervention is.
Thank you.
One more question. How do you know rectal remodeling doesn't occur with everybody and many people just are asymptomatic?
Yeah, great question. We don't, is the long and short of it. I think that it's important to note that half of the patients that underwent repeat biopsy had a normal biopsy, as defined by our very specific criteria, and that's why we included our pathologists in the review. And so I think long-term understanding whether rectal remodeling does occur in everyone is key. But from the study that we have and the data that we have, we don't seem to feel this is the case.
But you don't have that data.
Excuse me?
You don't have the data that people who are normal have rectal remodeling.
Sure, we don't have data that people that have not had biopsies don't have rectal remodeling. That's correct.
Yusuf Gohari from the University of Missouri. Did you look how many of these were long segment versus short segment Hirschsprung disease pull-through?
We did. There was no difference between the groups.
Sorry, one more question. When you do the biopsies, I'm assuming that you're doing the biopsies posteriorly in the rectum?
Yes.
Okay. Is there any way to determine whether or not some of the other patients that may be having problems are having problems because of anterior or left portions that are left behind that you're not able to assess?
Certainly could be the case. In terms of what we were able to study, I can't say.
Rajkumar from Australia. What's the timing of your surgery? Because I don't see so many obstructive symptoms like what you see. We operate on day 7, day 8. So I was just wondering whether your timing of surgery is relevant, because I don't wait for the last 5 years to 3-month surgery.
Sure. So there was no difference in our groups in in timing of the initial pull-through. Certainly, again, because this is a retrospective study, we couldn't control for that, nor could we standardize the timing of pull-through, but it's something that as we do this in a single institution format with a protocolized pathway that we intend to look at moving forward.
What's your standardized time? Do you operate at 3 months or 7 days?
It depends on the transition zone location.
Thanks.
Really wonderful presentation. Thank you so much.
Dear Chairperson, ladies and gentlemen. How do I? Okay, sorry. Okay, I have nothing to disclose. Congenital diaphragmatic hernia, or CDH, is a congenital malformation leading to fetal pulmonary hypoplasia. Compression alone can explain the development of pulmonary hypoplasia to a certain extent. However, the pathophysiology is still incompletely understood. Recent evidence suggests that hypoplastic lungs secondary to CDH have a multilineage inflammatory signature and are enriched with macrophages, which we have reported last year. And this was a surprising finding, considering that the antenatal period should be a sterile environment. The role of fetal lung macrophages in the context of lung development in general is not well studied, but we do know that macrophages can exert a pro-inflammatory status. As such, if you look at the molecular signaling cascade, the pro-inflammatory transcription factor NF-kappa beta P65 that has been reported to be implicated in CDH can translocate into the nucleus to induce the expression of pro-inflammatory cytokines such as TNF-alpha. And one could speculate that this pro-inflammatory signature might be responsible for impaired lung growth, impaired lung maturation, and also impaired lung vascularization that are hallmarks of CDH pathophysiology. So therefore, the aim of the current study is to verify whether macrophage knockout prevents fetal lung inflammation and pulmonary hypoplasia in an experimental model of CDH. We used either wild-type or CSF1R knockout mice, as CSF1R is the colony-stimulating factor 1 receptor that is expressed by all macrophages, and its signaling is important for their survival, proliferation, and function. We induced CDH on day 8 of gestation with nitrophen and bisdiamine, harvested lungs of fetuses with a diaphragmatic defect close to term, and analyzed their lungs for their degree of pulmonary hypoplasia. To do so, we compared wild-type animals and CSF1R knockout fetuses and analyzed their degree of lung inflammation, their lung growth via the radial airspace count, which quantifies the airspace density, their epithelial and mesenchymal maturation, and also their vascularization. So we first looked into CDH wild-type animals with normal macrophage function and could observe an increased gene expression of CD206, which is a surface marker of macrophages, increased protein expression of the transcription factor NF-kappa beta P65, and concordantly its downstream cytokine TNF-alpha. Now we switch gears and investigate CSF1R knockout CDH fetuses with impaired macrophage function in comparison to control knockout fetuses. And we could neither observe an upregulation of CD206 nor of the transcription factor NF-kappa beta P65, nor of its downstream cytokine TNF-alpha. And this leads to the conclusion that fetal lung macrophages are at least in part responsible for fetal lung inflammation in CDH. But are macrophage deficient CDH mice not only protected from fetal lung inflammation, but also from developing pulmonary hypoplasia? To answer this, we first investigated airspace density in wild-type animals and confirmed fewer airspaces in CDH mice. Interestingly, when we looked into CSF1R knockout CDH fetuses with impaired macrophage function, their airspace density was comparable to control macrophage-deficient lungs. And so with these exciting results, we then wanted to know if macrophage-deficient fetal lungs with CDH are also protected from developing impaired maturation and vascularization. So we first confirmed hallmarks of CDH pathophysiology in this CDH mouse model, including decreased podoplanin gene expression, which is indicative of alveolar type 1 cells, impaired mesenchymal maturation with decreased elastin gene, and protein expression. Next, we assessed CD31, which is a marker for endothelial cells on a gene and protein level between control and CDH fetuses, and observed decreased gene and protein expression. So now we switch gears again and investigated fetal epithelial and mesenchymal cell maturation in macrophage-deficient CDH mice. And strikingly, we could neither observe alteration for epithelial nor mesenchymal cell maturation between control and CDH knockout fetuses. Moreover, we also observed similar gene and protein expression for CD31, which indicates comparable vascularization of the lung between control, knockout, and CDH knockout fetuses. So in conclusion, there's comprehensive evidence with the data that I just presented that knockout of fetal lung macrophages in this experimental model prevents fetal lung inflammation and also prevented several aspects of fetal pulmonary hypoplasia. And this implicates that macrophages may represent potential biomarkers or even a therapeutic target to treat pulmonary hypoplasia in fetuses with CDH. With that, I would like to thank you for your attention, and I'm happy to take any questions.
Hey, thank you. Sun Young, I'm a resident from University of Nebraska Medical Center. I think I missed it. What was your model of congenital, the diaphragmatic hernia in your mouse model?
Yeah, thank you for your question. So the model is a mouse model of CDH where we induce CDH and pulmonary hypoplasia with nitrofen and bisdiamine.
Hey, Vikas Gupta from Vanderbilt. Awesome work from the Zani lab. One of the strengths of the nitrofen model is that most of the mice are born with severe CDH. But we know clinically that there's a subset of patients that have mild CDH disease, type A or B defects with relatively large lungs, but they still have severe pulmonary vascular disease. How do you all plan to study this in mild disease and help those patients?
Yeah, thank you for your question. So, of course, this model has some limitations. It's quite a strong model with the nitrofen and bisdiamine exposure, I agree. So what we're doing right now is we're using this ex vivo compression model that my colleague just presented, and we knock out fetal lungs to ex vivo compression to look at the effects of compression alone, basically.
Matt Harding from Houston. Dr. Great presentation, great work by the Zani lab, as everyone has noted. Promising work that shows improvements in something that we believe to be a fundamental issue in CDH, prenatal inflammation. And it's interesting that you looked at both vasculature and you looked at the development of pulmonary parenchyma, right? Potentially addressing these two topics. My question is, A, did you look at anything with regards to cardiac inflammation? We know that the role of the heart is becoming something that's really well known and is clearly linked to early negative outcomes. That's my first question. My second question is, have you done any functional outcome work? Say looked at early postnatal echocardiograms, which we can now do in rodents, or looked at early lung function or alveolar changes, which we can then sort of look to the next level for clinical application. Thank you.
Yeah, thank you for your question. So myself, I haven't looked into the heart of those pups, but we do look into the heart in our lab to see the effects on the heart. And regarding your second question, so can you remind me of your second question?
He was asking functional.
Oh yeah, functional, yeah. So we haven't done any functional studies on those pups. It's quite challenging technically to basically inflate those CDH pups at E18. We have done it in a rat model and have done some functional studies. It's probably not impossible. We haven't done it yet, but it's for sure technically challenging.
David Hacken from Hopkins, that was just beautiful work. And it sort of confirms some thinking in the field that pulmonary hypertension in CDH is not just a lack of vascular development. There's probably an inflammatory component, and your data supports that. But the remaining question is what's activating the macrophages in the first place? I mean, they belong in the lung. They migrate from the yolk sac to the lung. And so something must be turning them on. And I'm wondering if you could provide any insights. Have you done any microarray on these macrophages? And could hypoxia through HIF be turning them on? Because that's obviously a known pro-inflammatory stimulus. Great work.
Thank you for this brilliant question. So basically, we do think that compression plays a role in the activation of the macrophages. So if you look at other diseases, postnatally, I don't know, like carpal tunnel syndrome or herniated disc, compression alone can lead to the influx of macrophages and can activate those macrophages. We are doing more experiments. We're doing spatial transcriptomics on those lungs to basically discern what kind of macrophages are in there. Are those more alveolar or interstitial macrophages, and where are they coming from? We haven't done those experiments yet, but thanks for your question.
Just one more quick question for the interest of time.
Kunisaki, Hopkins, Baltimore. Really fantastic study. My question was just more translational in nature. Many, many years ago, steroids was in vogue, and now it seems like we're back to maybe re-looking at anti-inflammatories as an approach for CDH. And I know there's some experimental work going on with various newer generation anti-inflammatories, precisely probably to treat this, perhaps through NF-kappa B or other mechanisms. Do you have any candidate marker or the therapeutics that you're looking at to really get at this, and as well as the timing relative to the time of diagnosis of this?
Yeah, thank you for your question. So we did some experiments in this mouse model with a CSF1R antagonist. It's called GW2580, and we could reproduce some of those findings that I just presented here. We did it on E16 and then harvested the fetuses also on E18, so similar to the study here. But of course, we would have to investigate also side effects of this treatment. As you've mentioned, steroids, for instance, could have detrimental effects on brain development, so we would have to also investigate some side effects of specific CSF1R antagonism in those preclinical models, which we haven't done yet.
Thank you for a great talk.
Good morning. Thank you for the opportunity to present. We have no disclosures. Several centers have recently started to use bivalirudin as the primary anticoagulant in CDH ECMO circuits in recent years. However, there are no large-scale studies investigating outcomes. This is important because CDH ECMO outcomes are relatively poor, with about 50% mortality rates. If bivalirudin does increase survival in these patients, it's a relatively easy and accessible change to make at an average CDH ECMO center. Bivalirudin may be beneficial in CDH ECMO outcomes. ECMO is used for severe congenital diaphragmatic hernia cases in patients with severe respiratory distress. Traditionally, the circuit has been anticoagulated with heparin. However, recent anecdotal experience suggests that bivalirudin, which is a direct thrombin inhibitor with a shorter half-life and more reliable bioavailability than heparin, may be advantageous for CDH patients with higher survival, less bleeding, and lower rates of intraventricular hemorrhage. Our aim was to analyze the impact of bivalirudin on outcomes in CDH patients requiring ECMO. To address this question, we conducted a multi-center retrospective cohort study using the Pediatric Health Information System database from 2016 to 2023. We identified 4,517 patients with CDH from 47 children's hospitals. We excluded major confounders, including patients who underwent cardiac surgery or were admitted to a FIS hospital after 1 week of life, and ultimately ended up with a population of 864 neonates on ECMO across 35 children's hospitals. Our primary outcome was in-hospital mortality, and our secondary outcomes were complications and cost. In the graph on the left, we show the proportion of CDH patients on ECMO at each institution. The blue bars represent CDH patients who required ECMO, and red bars represent patients who were managed without ECMO. We then created a box and whiskers plot that you see on the right to identify centers that were significant outliers in terms of volume. We excluded these 2 centers from further analysis. A version of these data were previously presented at the Academic Surgical Congress in February. This graph shows the use of bivalirudin over the study period, with patient-level use shown in the blue circles and institutional use shown in the red triangles. By the end of the study period, bivalirudin use in CDH ECMO had increased significantly, both on an institutional and on a patient level, with rates nearing 50%. Overall, 15% of infants were treated with bivalirudin. There were no major differences in gestational age, APGAR scores, or sex between groups. Patients receiving bivalirudin had lower birth weights, with just over 100 grams lighter compared to the heparin cohort. Patients on bivalirudin were more likely to be repaired overall, with higher on-ECMO repair rates. They were also more likely to undergo surgical repair at a younger age. However, this was balanced with a significantly longer ECMO duration in the bivalirudin cohort, averaging an additional 4 days. There was no difference in the number of days on mechanical ventilator. There was no difference in the complication profile, including bleeding, thrombosis, or intraventricular hemorrhage. And importantly, there was no difference in overall survival. In the Kaplan-Meier curve on the left, patients receiving heparin are shown by the blue line, and patients receiving bivalirudin are shown with the red line. There was no difference in overall survival, with a p-value of 0.27. Resource utilization was significantly higher in patients receiving bivalirudin, as evidenced by longer lengths of hospital stay, 120 versus 101 days, and significantly higher cost of care, nearing 1.5 times the cost of heparin-only patients. In conclusion, this multi-center study shows no evidence that bivalirudin has superior outcomes compared to heparin when used during ECMO support of infants with congenital diaphragmatic hernia. Despite the apparent lack of benefit, its use has increased significantly over the past decade. After excluding outliers, the overall complication profile of bivalirudin is similar to that of heparin, with no survival benefit. Bivalirudin was associated with significantly higher resource utilization in terms of ECMO duration, hospital length of stay, and overall hospital charges. The study is subject to several limitations, and for this reason, future prospective studies are needed. Thank you.
As people are coming up, I wanted to clarify, so your 2 cohorts were heparin alone and then bival with or without heparin utilization, is that correct?
Correct. So typically the circuits are still primed with heparin. So any patient who received a dose of bivalirudin was included in the bivalirudin cohort.
And were you able to subset or look specifically at populations of patients who were started on heparin and potentially had complications that were thought to maybe be related to the heparin utilization and then switched to bivalirudin, and how could that have possibly impacted your results? Thank you.
Thank you. We did look at that. There were very few patients who were transitioned from heparin to bivalirudin due to complications based on the data that we were able to look at in the FIS database. It's obviously one of the limitations of the study, but most of this seems to be an institutional protocol change.
Thank you. Sun Young from Nebraska. So what was your reason for excluding the cardiac patients undergoing ECMO if you were really strictly looking at the role of bivalirudin versus heparin?
Thank you. So bivalirudin has been used in ECMO for cardiac indications for some time in the pediatric population, and so we thought that may have been an outlier or a confounder that may have been the indication for bivalirudin use as opposed to institutional changes or other metrics.
Hi, George. Oh, that's loud. George Mihalishka, Ann Arbor, Michigan. Beautiful presentation and great study. I guess my comments are, there's so many confounders in this retrospective study, and there's not a lot of
risk stratification for severity. So it's really hard to draw a conclusion, in my opinion, like the longer ECMO course could have been because of severity for a number of different factors. So I think it's hard to have robust conclusions from this study.
Thank you, absolutely. It's one of the limitations of working with databases for sure. We have attempted to kind of mitigate confounders by looking at specific institutions themselves. Oh, it won't let me advance my slides. In these graphs, you can see this is essentially looking at pre and post bival eras. So for each institution, we had grouped every CDH patient who was treated before the first instance of bivalirudin in the pre-cohort, and every patient who was treated at that institution, regardless of whether they were treated with heparin or bivalirudin, after the first introduction of bivalirudin at that institution in the post-cohort. And even looking at this, so the same institutions, which should have about the same severity of CDH, there's no difference between the two. The p-value here is 0.51 for the Kaplan-Meier survival curve. Again, not the cleanest data. It is a data set, but we've tried to mitigate that as much as possible.
Olutoye, Nationwide Children's. Really enjoyed your study. Very nice presentation, nice study. I wanted to flip it on its head a little bit. I know you excluded the 2 centers that had the largest number of patients. But if you actually looked at those 2 centers, they probably had more patients almost than the combined rest of the group. And so when you're looking for small changes, is it really worth going back to look at those 2 centers and actually see, with their bival use, could you actually see a difference? Because again, with all the confounding factors and small changes, are you actually losing the effect of it because each of the centers have so small numbers that you're not able to see it? Are you able to see that when you actually look at those centers with lots of patients?
Thank you.
Really nice study.
Yes, thank you for the question. You're absolutely correct. So our intention with this study was to investigate the impact of bivalirudin at the average CDH ECMO center. We had looked at the data in several ways. Those 2 centers do skew the data significantly. I also have those slides, if it'll let me go back. When we look at the survival for all patients, including those 2 centers, it looks like the bivalirudin cohort does do significantly better, with significantly more mortality in the heparin group. We feel like those results are due to factors other than the use of bivalirudin at those institutions. So things are very protocolized. The resources are significantly different, and for that reason, we had decided to exclude those high-volume centers.
All right, great. Thank you. Very nice.
Well, thanks for sticking it out to the end here. And thanks for the opportunity to present some of the work we've been doing recently at Wake Forest and at the Institute for Regenerative Medicine there. Oh, big green, got it. Okay, we have nothing to disclose. So we performed this research as a step towards trying to develop functional tissue-engineered small intestine that we hope will eventually undergo coordinated peristalsis. It's important because we've developed a relatively easy method to fabricate a tubular scaffold with design features that will encourage smooth muscle cell alignment, which will be important for coordinating that contraction in the future. So I don't need to tell this audience about short bowel syndrome. It's a disease that we all often see. It's most commonly caused by NEC, which we've discussed already at this session. The incidence is difficult to estimate, and although it's not very prevalent, the all-cause mortality is still about 23%, most of that being due to TPN and central line infections. But in addition, the treatment costs are extremely high, estimated to be $2.3 billion annually in the United States. Treatment is clearly multimodal. It involves TPN as the mainstay, as we've mentioned, as well as these other modalities like continuous feeds on G-tubes, et cetera. But the goal of all these treatments is really to come off of that TPN and achieve enteral autonomy. And it's been estimated by the Intestinal Failure Consortium that with every 1 centimeter increase in bowel length that you can give a patient, you increase their odds of coming off TPN by about 4%. So our goal here is to engineer any amount of functional intestine, not necessarily the entire intestine, which of course would be amazing, but we're far from that. Intestine is obviously very complicated, but breaking it down into an engineering problem, what does it need at a minimum to function, and it needs to be able to absorb nutrients, and it must undergo peristalsis, not only to continue moving effluent through the intestine, but to help, continue to help the epithelium absorb. So for absorption, you need epithelium. For peristalsis, you need organized muscular layers, as well as an enteric nervous system. For this work, we decided to focus on the peristalsis function, and therefore wanted to design a construct or a scaffold that would encourage organized muscular layers. We used a classic tissue engineering strategy where you take your cells of interest and put them on a three-dimensional construct, and that's really where the purpose of this work. Ultimately, these constructs will be implanted in the omentum to mature and then placed in continuity. But we hypothesized that we could find a way to develop this three-dimensional construct that would encourage intestinal smooth muscle cells to align in a circumferential direction. To do this, we used an electrospinning technique, which is an old textile industry technique where you can take polymers and dissolve them in organic solvents, apply very high voltages to a syringe, eject it out of the syringe towards a grounded cylinder that's rotating that we call a mandrel, and it collects these fibers that are on the micrometer to nanometer scale. For our study, we used polycaprolactone, which is an FDA-approved polymer that has a very slow degradation time, blended with type 1 collagen. And we wanted to see if we could, one, get aligned fibers, but two, if the aligned fibers actually would induce muscle cell alignment compared to non-aligned fibers. And so you can see in the panel B there, our highly aligned scaffolds at 11,000 RPM. So if we increase that rotation speed on the mandrel, we can increase the amount of alignment of the fibers compared to our slow rotating mandrel at 1,000 RPMs, which is essentially a non-aligned scaffold. And these scaffolds had average fiber diameter between 3 to 4 microns and porosity between 80 to 85%. And we tested a rotation speed of 9,000 as well, which is sort of in between the two. When we looked at these with scanning electron microscopy, we could see that with higher rotation speeds, we generally got more alignment both on the inside and outside of the scaffold. And to further confirm this, we tested the tensile properties of these constructs, both in the parallel direction to the fibers as well as in the perpendicular direction. So we opened up the constructs, laid them flat, created dog bone specimens in the parallel direction and then in the perpendicular direction, and then did tensile testing. If you focus on the red curves here, there's a little bit of a complicated graph. We're looking at the tensile properties both in the parallel direction, so the solid lines, and you can see that they are much stiffer, so a steeper slope, and stronger, so a higher peak, compared to when they're tested in the perpendicular direction, which is the dotted lines. In contrast, if you look at the 1,000 RPM scaffolds, which are in the black lines, the testing is relatively similar, both in the parallel and perpendicular direction, again confirming that we had developed these aligned scaffolds. Finally, we isolated human intestinal muscle cells and seeded them on the scaffolds. And as you can see, as we had seeded them on scaffolds with increased alignment, we got more aligned muscle cells. So in the 1,000 RPM scaffolds, they were relatively haphazardly oriented. And as we went up to 9,000 RPMs, they got more and more aligned in that cardinal direction, which here is left to right. So in conclusion, we developed an electrospin scaffold that has aligned fibers. These fibers seem to induce smooth muscle cell alignment in the circumferential direction, which we think will be important for coordinated peristalsis in the future. And we think it holds promise as a building block for our tissue-engineered small intestine program at Wake Forest. Obviously, there's a lot still to do. There's a nervous system that we're just now starting to look into and trying to isolate the cells needed for that. Ideally, we would have a longitudinal muscle layer, and eventually we'll have to add in the absorptive layer as well. So with that, I'd like to thank all my co-authors and for this opportunity, and I'd be happy to take any questions.
James Dunn, Stanford University. Very nice work. Much of the work on tissue engineering intestine have focused on the epithelium before, so I congratulate you on focusing on another important element of the intestinal function. We've done similar work before with these aligned type scaffolds. I'm curious to see if you have done any work to look at the actual contraction of these scaffolds with these seeded smooth muscle cells, because we found that PCL fibers tend to be pretty stiff, as you've shown, and that the muscles cells aren't really able to contract them.
Yeah, we have not as of yet. That is true that polycaprolactone can be fairly stiff. We can adjust that to some extent by adjusting our blend ratio of collagen to polycaprolactone. But as a starting point, we sort of did a 1-to-1 blend, so it's something that we definitely need to investigate. And some of that will come with our in vivo models as we move forward.
Hey, Mitch, really great job. David Hackman from Hopkins. So along those lines, tell us a little bit more about the utility of the scaffold. So does it hold stitches? Does it melt away when it gets wet? And also, what about porosity for vascular ingrowth to support these scaffolds when you implant them in the body to keep the muscle cells alive or your enteric neurons alive. Great work.
Yeah, sure, thank you. So they actually are pretty durable in that way. So when they're wet, they're definitely not as supple as, say, intestine, but they don't just disintegrate. They hold stitches quite well. We have some data for that. We have done some in vitro degradation studies, and they hold up pretty well for quite a long time, which, we're not sure if that's going to be a good or a bad thing yet. But even out to 6 months when they're exposed to sort of fluid that mimics enteric succus, so it's got bile acids and other things, and they still hold up pretty well. Now, by 6 months, they're much more brittle, and they do kind of start to fall apart at that point, but for the first several months, they're quite good. In terms of the blood supply, which is your, I think, second question, they have pretty decent porosity. In fairness, the fibers overlay each other a lot, so we'll have to see how well the vascularity grows in. We have a little bit of preliminary data that we didn't present here, where we have put some of these just in the omentum. And it seems like, although we're still sorting it out, that the smooth muscle cells do survive in that scenario, but more to come on that.
That's wonderful. Thanks.
All right, well, thank you for a great talk.